For today's case of the week, I wanted to share something with you that's been a particular frustration of mine over the last 12 years that I've been here at the laboratory. And it's with one of my favorite products here at the lab, which is BioTemps. And we look at this patient who we've already prepared. Of course, it's a typodont, and you can see we've prepped from first molar to first molar, from 3 to 14. And this is a case, any kind of case like this, I'm certainly going to use BioTemps. In real life, the patient's probably missing a tooth here, maybe a lateral here, and another bio over there. And so we're going to want the BioTemps for the strength of the bridge. But anytime we're prepping this many units, if it's 4 full crowns, I always am going to do a BioTemp. And it's not just because I get them for free. It's because they look so good, and it really can simplify the whole process of temporization. But then sometimes things kind of go off the rails, and things are actually more difficult than they would be with a chairside temp. It's not that a chairside temp would be impossible here. It would just probably take a lot longer than a BioTemp. Unless the BioTemp's not fitting, then that's going to take a much longer time, and you might not even have a bailout position. So let's take a step back real quick. Let's pretend we haven't prepped the patient yet. This is what the patient looked like when they came in. So we have some alignment issues, and we're going to go in and prepare all these teeth for crowns once the patient gets here. But even before that, we're going to send this model to Glidewell and ask for BioTemps for these 14 units. And so here's what it looks like when the technicians have had a chance to prep the model for BioTemps. They are under strict direction not to remove more than a millimeter from any tooth structure here. And as we zoom in a little bit tighter, you'll see they do try to be very conservative with their planes. You know, they do, of course, mimic the occlusal surface, which is sometimes, why tabletop preps don't work, but they try to be very minimal in their axial reduction and at the gingival margin. All they're trying to do is eliminate undercuts from all these preparations because they want to make the BioTemps as thin as possible. And so here's our BioTemps restoration as typically ordered by a dentist. It's got the wire reinforcement, and again, it goes from tooth number 3 to tooth number 14. And even with this minimal amount of preparation, so for example, on this patient we're doing EMAX, even with this minimal amount of preparation, which is not enough for EMAX, the shell of the BioTemps fits onto the preps quite easily. And there's no undercut problems. It just comes right on and off of those preparations. And when you show this to the patient, they'll get very excited. You'll look at it and you go, wow, these temps are going to look awesome. We actually have a scan and save program now with the BioTemp product where if you put these in the patient's mouth and you both look at them and the patient says, oh, those are gorgeous. We've already scanned what these BioTemps look like in the lab, and you just say, hey, replicate exactly that in EMAX. It's really the first time we've been able to do this. We used to try to approximate it by hand, but now we can actually do it digitally. So if you like how the BioTemps look or the patient loves it, we can make you teeth, individual crowns that are the same size, shape, length, contour, surface texture, all that good stuff, and replicate that from the BioTemps into the permanent restoration. So again, with minimal preparation, these fit right into place. And so now we prep our patient for EMAX, which requires more of a prep. In fact, when you look down here, you'll notice you can see the margins all the way around as we look down here, which we couldn't see on this because they really didn't prep any margins. So we actually have more reduction here than we did on the model that the BioTemps technician did. But here's the issue when we tried to put the BioTemps into place. And I've had this happen countless times, and they just don't go down into place. What we want is a passive fit. These should fall into place on the preparation and just seat all the way down, just like they did on the other model. Remember, on this prep model, basically all I had to do was take this and just slide it into place. I mean, no effort whatsoever, just sliding it into place, again, on a minimally prepped tooth. And then here we go to our patient, our real mouth, where we've actually prepped it more than that, and it won't go down. And this was a big source of frustration for me, and continues to be to this day. So let me show you a couple ways around this issue. The first way is to actually order the BioTemps in segments. This is something that I started doing years ago, and it cleared up a lot of these problems for me. So what that would look like, and I typically keep it as you're going to see it here, with one segment from 6 through 11, and then 2 posterior segments. And of course, if the second molars were on here as well, we would just include those on the posterior segments. So now we have 3 different segments of BioTemps that we're going to reline individually. In a case like this where we're maintaining the patient's bite, the vertical dimension of occlusion, it's very easy to do. We would just prep these 3 teeth first, and then while we finished that and took our impression, my assistant would make the temporary using the rest of these unprepped teeth to maintain that vertical, and then those BioTemps would be done. Then I'd probably come over here and prep these 3 teeth and get those done, and then if we had time, I'd move to the 6 anterior teeth. I used to come in and give anesthesia here and anesthesia here and anesthesia everywhere and then run out of anesthesia because I'd prep these and then these would be waking up. So now I just do it a segment at a time without rushing too much, because this way if I end up getting these 2 prepped today, these 6 preps and the temps are all in, now I can let the patient go if need be, if they're getting exhausted or I'm getting exhausted, and have them back and do these 6 in a week or so, because I've maintained the vertical here. So when we take those segments to the patient's mouth, we'll just pretend that we did prep all of these, and I go to place these 6 anteriors into the patient's mouth. You'll see all of a sudden now we're very close to having passive fit all the way down. We just have a little bit of material that we're going to pick up in the reline material, and there's no problem with that at all. The beauty of the BioTemps is what you see on the incisal edge and the rest of the tooth. If we have a little bisacral margin up here, that's going to be fine. So all of a sudden now we've got a much better fit when we have that segment put into place. And then we'll take a look at a couple of the posterior segments. And again, nice passive fit there without too much issue. And same thing over on this side. So whereas with our full splinted BioTemp, which is certainly easier to deal with from the standpoint it's just one big horseshoe, one big unit, it would not go down into place. And I would always ask myself, well, wait a minute, I prepped more here than I did here. What's going on? And it typically has to do with the mesial and distal surfaces on the preps themselves. See, we prep this because we know this is going to be 14 single units of Emax in this case. When this was prepped, the one thing that the BioTemp preparation technician had in mind was, I need to make all of these preps draw so that I can get this big temporary bridge to come on and off with no issues. We weren't thinking that when we prepped these teeth. We prepped these teeth as individual crowns. We did not worry for a moment about whether or not these were all going to draw together, because this isn't a bridge. And so the disconnect between this is the fact that we've prepped individual crowns and the technician here has prepped as though this were one big bridge. And of course, it's much easier to do that staring down at a model than it is in the patient's mouth with a mouth mirror. And that's why a lot of times making it one big segment like this doesn't work, and it won't go down and you won't have passive fit. So what can you do if you did order it this way and you didn't order it in segments? Well, the first thing is, one of the things that you can request, and I request this on every single case, it's called a prep guide. And what the prep guide is a suck down, a thermoform splint that goes over where the BioTemp technician prepped the teeth. And so they do a suck down over that. So if I have a large BioTemps bridge that isn't fitting, I'll take the prep guide and I'll put it into the patient's mouth. And this is going to give me an idea of where I haven't prepped enough. Now, in some cases, it's correct. In some cases, it'll be touching, and I'll go, oh, I under-reduced there. Although, honestly, since I started doing the reverse preparation technique, that doesn't happen very often anymore. But it can happen interproximally. We don't place depth cuts with the reverse preparation technique on the mesial and distal surfaces, and so sometimes I'm under-prepped there. But you can get an idea when you put this in if, in fact, you have reduced enough everywhere. And you may have reduced enough everywhere, you just don't have draw between all of those. But sometimes it'll show you where you're under-reduced, and that's actually a nice thing. So if you try that in, you see some areas where the tooth is touching the stent, you can go in and make any adjustments you need to, and then see if the BioTemp bridge will go into place. If it doesn't, typically the next thing I will do, you really have one of two options here. When you look at this bridge, you'll notice that, again, my feeling is that it's the interproximal areas that are keeping this from seating all the way. So the first thing we can do, or one of the things we can do, is blow out all the interproximal areas between the teeth. When you think about it, we really don't need these interproximal areas that we see here. You know, when you look at some of these areas here, this is just something that happens to be there because it was made on the model, but if we blow that out and get rid of it, we're going to pick up those interproximal margins with our reline anyway. So I will often do that first, where I will go in and actually just kind of blow out some of those connections. So just on a couple teeth here, I literally just come in. I'd use a burr, probably a little pointier as I got to the anterior. But I don't need these connections. You know, I'm turning this into a taco crown of sorts. All of a sudden it's becoming like a facial, occlusal, lingual shell without any interproximal connections here. And so you can just go through here and blast all these out. Because again, when we reline these on the teeth, we're going to pick up all this information. In fact, you could almost have the BioTemps made without it if you wanted to. But I typically have it made with it because it's nice. It leaves much less finishing if you're able to have these interproximal contacts in place when you do the relining. It's a little wide here. I don't want to break through to the facial, but again, something a little thinner at the tip does a better job of breaking those connections. So once you've had the opportunity to go through and cut all those, you can try it back on the model again, or in the patient's mouth, I should say, and see if you have better fit. You know, we've got a little better fit there. Of course, I didn't blow through the anterior ones, and a lot of times it's the anterior teeth where it's getting hung up interproximally. Another choice would be to take this and turn it into our segmented model. And I don't like this way quite as much because it leads to a little diastema issue at times. But certainly, when you've paid $25 a unit for this times 12, and the patient's, you know, counting on having some really nice temporaries when they walk out because you told them how nice they were going to look because they were worried about what are my teeth going to look like for 2 weeks till I get the permanent crowns. You want to use this. You don't want to let this go to waste. And so this is necessary sometimes to be able to use this. So basically what we're going to do is turn this into a segmented BioTemp. And again, we have the wire reinforcement here, about the thickness of a paper clip. So that's why I'm using this diamond disc to cut through here. And so basically all we're going to do is just separate it like the other ones were separated by segmenting it distal to the cuspid, between the cuspid and the first bi. And then once I've segmented it, I'll go back in with that other burr and polish it a little bit, both sides of it, especially to make sure that wire is not pointy. And so now again I have a segmented one and I cut it on the other side as well. So now I have these two 3-unit ones that we're going to reline separately, and then our 6-unit one in the anterior. The downside of doing it this way is typically you almost always end up, after you polish it, with an open contact between these two teeth. So you'll put these both in and reline them and take them out, and there'll be an open contact. I just fill that with some flowable composite. I just put flowable composite in that undercut and cure it, knowing that it's not perfect, but I don't want the patient getting things packed in there and I don't want them to have a space. So because of that reason, we put a little flowable composite and just cure it in there. It'll stick well enough to the outside because the glaze that's on the front of the BioTemps has been removed by us cutting and then reshaping over here. So the two ways to do it, my preferred way would be to hollow it out first and keep it all as one piece because it's much easier to deal with as one piece. If it still doesn't work, I would cut it into sections, and at that point it usually almost always will go down when we just have the 6 anterior teeth isolated from the 2 other 3 teeth sections. If it still doesn't work at this point, the one last bailout position that I have is my second stent that I ask for with every BioTemps case. So the first stent that I ask for is the prep stent, and that's the suck down that's made over the prep model. And the second one is the suck down that's made over the BioTemps themselves. So if you look at when it sits down on top of the BioTemps, they've just done a suck down on top of that for me. I call this the Bailout splint or the full contour splint, but I colloquially kind of refer to it as the Bailout splint because now I have a suck down of exactly what those BioTemps look like. So if I just can't make this work and I'm getting frustrated, there comes a point where you have to do something, and you might have a pre-impression, but again, on this patient, you know, if we had a pre-impression and we're making temps, they're going to leave looking like this. They're not going to be thrilled about that. We kind of said there would be an aesthetic improvement right after the first appointment. So we have this suck down of the BioTemp. So now I'm going to take this, I'm going to fill it with bisacryl material. So I'll fill it with something like Luxatemp and then seat it down onto the preparations like such. And now all of a sudden we're going to get a big chairside temp connected all the way around so we get some nice bulk, some nice strength. And the actual Chairside Bisacryl material is going to have the same size and shape of the BioTemp. So it's going to be the same kind of arrangement, except it's going to be Chairside. It's going to be in Bisacryl, so it won't be as strong. It won't have the wire reinforcement that we have in the posterior. You know, it won't have the super nice glaze like we have here, but it's going to be pretty darn close. At least it's the same size and shape, and at least the patient leaves with some nice looking provisionals where they've actually had some aesthetic improvement for how they walked in the door. In fact, some doctors actually like to use this, you know, what I call again the Bailout splint for their reduction. So they'll put this over the preps and look to see how much they've reduced, and have I reduced enough? Do I have enough room between the stent and the prep for the final contours or whatever required thickness is for the Emax in that area? So they'll put this on over the preps as well and check it, and that's fine. That's a good thing to do. Sometimes I'll poke some holes in it, put a perio probe in just to kind of to measure that as well. Although I do like to use, as I mentioned, the prep one before, just to make sure I removed at least a millimeter like the BioTemps technician did. So hopefully I've gone over a couple things here that you may or may not have found frustrating in the past. Anytime you're doing a larger case like this, I always recommend that you just have them made in 3 segments right off the bat. It's a little more of a hassle to deal with, I understand. Sometimes I'll even take the 3 segments like this, and you can either make like a little putty hot dog and mix up some impression putty and put it over here and try to seat them all at the same time. I've done it before, and I know doctors who will take this splint, you know, the Bailout splint, and put it over there and then take it all off together and put the bisacryl in and then seat them all together in the patient's mouth just to make sure they get related to each other properly. But for me, I don't have any issue doing this segment first and then this posterior segment next and then prepping these last. And yeah, sometimes we have to adjust contacts here to get that to go down, just because when they sit on preps, oftentimes they'll have a tendency to rock a little bit based on the reduction. They can rock facial lingually, and you just want to make sure. They tend to always rock to the facial, and so you want to make sure when you reline these that you have the patient bite together, and before you reline it, when you're just trying it in passively, and make sure they don't look Bucky Beaver. I've never seen them tilt back to the lingual. They always tilt out to the facial, which is good for giving you room for the occlusion. But you want to make sure that your patient doesn't leave, you know, looking like John Elway with some huge anterior teeth. So we'll often check that, and that's why some doctors like to seat all 3 segments at the same time. So again, BioTemp's one of our best products, a magical way to give a patient just some wonderful temporaries. But because of the fact that we're prepping for single units and the techs are prepping for a restoration that's going to draw, there's discrepancies here that make it difficult to use at times, and I hope I'd cover some handy solutions for you.